Спасибо. Если вопросов больше нет, мы тогда можем двигаться дальше. I would like to invite our next speaker, Dr. Pritam Majumdar. He is a functional neurosurgeon from India, from Institute of Brain and Spine Hospital. So we thought to meet in Kazan and discuss many things in collaboration and related to current data, but unfortunately, again, because of all those issues with flights, yeah. But again, I'm really glad that Dr. Majumdar was able to join us online, and he will present his talk, Epidural Stimulation, New Hope for Spinal Cord Injury and Future Directions. Again, thank you so much for being with us. Please share your thoughts.
Yeah, I got. Thank you so much for this welcome for this conference. And yes, I was really looking forward to see this, to join this conference physically, but unfortunately, because of this Russia and these other things, I could not come. So, but it's okay. I tried to put something, in the experience of for the spinal cord injury patient, how we treat, especially for the patient, those who have the spinal cord injury, maybe it's a complete or incomplete. I'm just trying to put all those in one thing. Just give me a minute.
There is an icon open shared. Oh, okay, yeah, it works. Awesome.
Can you? So can you see that? Is it okay?
Yeah, I think it's good.
Yeah. So I'm going to talk about something what we do. The spinal electrical stimulations. We usually call this is epidural stimulation. Also, that we have done around 200 patients so far in India in last 2 years. And also other countries like Turkey, and also we treat patients from Germany. We do from other European countries patients, those who comes to us for the treatment. And we have done this stimulation for the patient with a complete spinal cord injury, and also we have treated with an incomplete spinal cord injury also. So this is just a little introduction about the spinal cord injury patient when we talk about it. So when the patient has a complete spinal cord injury, so we usually have a motor functionality damage as well as the sensory functionality damage also. And improvements, especially standing and and stepping, it is very less reported by the non-invasive stimulation so far it's available. There are few other steps also we do, like non-invasive spinal cord stimulation also we do in our center, and we do only for those patients who has an incomplete spinal cord injury, like those who are in Asia B or Asia C. For them we do non-invasive spinal cord stimulation, and those who comes to the Asia A state, so we usually give them an option for this electrical spinal cord stimulation, that the epidural stimulation. And improvements with if you see the incomplete spinal cord injury patient, what we have seen, that after some time with the locomotor training or non-invasive some stimulations, and also the FES, nowadays the many rehab center, they combine FES as well as. So we have seen over a period of 2 to 3 years doing all those things, they usually get some improvement with some braces, they able to work. But if you consider about the complete spinal cord injury, for them it is very difficult to get back on their on their feet, or to walk by themselves, or with a walker. So that's the reason we started doing this EES, which is called as the epidural electrical stimulation, because of that. So now there is a good question I always counter whenever I talk about it, that they said that why you talk about this is a epidural electrical stimulation rather than the spinal cord stimulation. So in spinal cord stimulations, we usually stimulate to the spinal vertebrae for the pain. And here in epidural stimulation, we try to stimulate to the conus area. Those are the region from where the network activities arises for the lower limb movements. So we usually stimulate to the epidural of the region of this conus area. So that's the reason I usually say this is a epidural electrical stimulation. And in 2020, there are few hypotheses regarding this epidural stimulations came up. So from that is Dofrel, So he gave 3 hypotheses into this. So I'll not go to this hypothesis direct because it's too deeply. So the main hypothesis, what he said there is a 3 things involved in a spinal cord injury patient, and one is in the proprioceptions, like when patient has a spinal cord injury, so there is a sensory loss. So for that patient not able to feel and all those. So he said there is a monosynaptic connections between the 2 different afferents and the motor neurons. Those usually get damaged. So in the mechanism of this electrical stimulation, somewhere we stimulate to these areas, so which usually gets back the patient the afferent networks pathway, so the patient can able to feel some kind of sensations. Second hypothesis, he says that is a reorganizations of the proprioceptal circuit. So when we stimulate to the conus region, which comes from the T11 to the T11 to the L1 region, they said when you stimulate to the prospinal circuit, so that usually give the central nervous system the rhythmic activity, those which usually coordinate between the brain, the sensors to the lower limbs to the functionality. And the second hypothesis, what he mentioned, there are many other internal neural networks are involved into it. So when we stimulate to the particular area of the spine, it doesn't mean that we are only getting the movements, because with this we have treated what we have experienced, that this epidural stimulation can take care of the spasticity, it can improve the sensory, it can improve the bladder and bowel, and also it improves the patient ability to stand and the walk, which we are going to show the next. So now, how you select?
I apologize. I'm not sure if your slides are moving, because I still see the first slide.
Is it okay?
No, I'm not sure how everyone. Yeah, I still see the first slide. I don't see them moving. Коллеги, у вас слайды двигаются в зале?
No, this first slide, spinal electrical stimulation was spinal at work.
Okay, now it's good.
It's okay?
Yeah, now it's good. Yeah, so now we can see them.
Okay. So this was the slide where I was talking about the hypothesis about 3 different hypotheses. So this is the slide, and this is our criteria how we do the patient selections for the epidural stimulations. So first we usually do the neurological level of assessment, like the ASIA scale, which scale the patient is. Then this ASIA scale we usually differentiate from ASIA A and to ASIA B to D for the incomplete and complete. And once this is come, so which comes with a manual muscle scaling we do, because after spinal cord injury, patients usually have a severe muscle wastings. So we need to see that also, that how much muscle wasting patient has. And in the muscle wasting, why we test, because we have seen after spinal cord, like after epidural stimulations, the patient usually gain back some kind of muscles power. So from the MAs, like the scaling from what we started before electrical stimulations and after the EES, we have usually calculate that how much muscle growth we have seen into the patient. And the third thing, we see the sensory scaling. It means the soft and touch and the pin prick, how the patient is responding. And the fourth one is a whiskey scaling. It means working index for the spinal cord injury patients. And the last one is a mass scaling for the spasticity. Because in spinal cord injury patient, if it is a complete or incomplete, the spasticity always a bigger challenge. And 90% patient comes with the spasticity. Only 10% patient comes without spasticity or lower grade of spasticity. So now this is some surgical details, like how you do the placement of the epidural leads onto the spinal segment. So we usually do what we do. So first we usually get the MRI scan. If I go to the next, it will be better. So here if you see, so first we usually get the MRI scan, and we usually identify that which level it will be the conus, because it's nothing to do with the injury level. Suppose patient has a D7 to D8 injury, or patient have a D5 to D6 injury, we usually don't follow this. We usually follow where is the conus region and the conus is intact or not. So when we see that yes, this is the conus region and conus is an intact, then we go with the open laminectomy, and this is the electrodes we use from the Medtronic 565. So we open laminectomy we do. We put the electrodes and then we anchor the electrodes. This back where it's anchoring. and after the anchoring, this is the scan what we get. So we always try to keep our electrodes to the base of the T11 vertebrae to the L1 vertebrae. So T12 is the region where we usually see the patient's conus. Some patient, if it is, you know, usually patient with male and female, they have a different kind of conus structure. So usually male has a T11 base to the L1 upper base to the conus region. For the woman, it usually starts with the T11 half to the T12 half. So this, the MRI scan what we have taken, it is from a male patient, and in this patient we have put the electrodes from the T11 lower base to the L1 upper base. So we usually cover the complete conus region. So here itself we mentioned this. So this is the scale that first we get the MRI scan, we finalize it where is the conus region, and the second, when the conus region is done, we take the patient to the operation table. We usually do open laminectomy from L2 to T11 area, and after that, you know, we usually remove the lumbodorsal fascia of the level from the spinous process. So wherever the level is, then we go to the vertebra level, and once we go to the vertebra level, we first put the electrodes. So in this, see, if you see, first we put the electrodes into this region, and after putting the electrodes, we stimulate on table, and sometimes we need to adjust the electrodes little bit up or little bit down, depends on how the patient's responses on the, you know, on EMG basis. Because when you do this stimulation on table assessment, we take the nerve conduction study also on the same time to find out that how much patient is getting the responses on the nerves. So this is the intro of neuromonitoring for the muscle electrophysiology. So we usually take Medtronic 16 contacts 565. We usually go from the T12. So for this case, we put it in the T12 to L1. So we usually go to the midline of the dura, and T11 to L1 vertebrae we put the electrodes. And when we do record the electrodes, you know, when we stimulate to the on table, we usually keep focus on the 4 muscles. One is in rectus femoris, second one is in the hamstring, third one is the tibialis anterior, and 4 is the gluteus maximus. These are the 4 muscles we usually try to see in the both legs when you stimulate, how much responses we are getting. And when we start the EES, you know, the epidural stimulations on table, we usually start from 0 volt, we will go to 10 volt, and we keep the frequency from 0.5 hertz to the 1 hertz. Sometimes we go to 10 hertz also, because in the intra-op, if we go with a more higher frequency, sometimes, you know, the nerve conduction study, the responses gets damaged, or it's became some kind of artifact. So that's the reason we usually try to keep the frequency of the stimulations as low as possible. So this is one. So the graph, when we stimulate to the on table, how we get the, so this is a right tibialis anterior, if you see. So when you stimulate, we can see how much patient is responding with the stimulations, and this is for the right soleus. So this also responses that this is when patient has a minimum current, this is the response. When you go to the higher current, how much patient is responding with the stimulation. And post-operative, most important thing is how you do the programming. See, now the thing is, every few places in the world, they say that they do epidural stimulation for spinal cord injury patient. But the most important thing is how we are going to manage the patient post-operatively. Because post-operatively, the main function comes about the programming. And every center, they have a different technology and different ways to do the programming. As in our center also, we have a different protocol to do the programming. So we usually, after the surgery, for 5 to 6 days, we don't do anything. We keep the patients in a completely resting position, because we need to heal the wound. And once the wounds, we see that that's completely healed, then we take the patients to our neuro rehab center for programming plus the locomotor training. Now, in the locomotor training, initially for 2 weeks, we give the Cyberdyne training, because in our center we have Cyberdyne. So first 2 weeks we give Cyberdyne without epidural stimulation current. So first 2 weeks, it's that we make the patient stand with the harness, and we usually try to get the patient's the stepping pattern to generate. And in that 2 weeks time, we combine Cyberdyne to get the locomotor training also as well as. And after 2 weeks, we started the patients, once the patient stepping pattern generated, then we put those patients into the walker with a harness, because some patients has a good knee, good hip control, some patients has a very mild to moderate hip control. So the patient who has a good hip control, they don't need any support, no the harness, so they can work with the walker. And the patient who needs the hip control, so we have a platform walker and we put the patient to the platform walker with the harness with the stimulation on. And what are the results from that? So after stimulations, those things, we have seen patient after 2 to 3 months. Patients improved in 4 different aspects. First one, lower extremity motor scaling. So like the patient who has before the surgery 0, and after 8 weeks, like approximately after 2 months, we have seen the patient's improvements. It is around 18 to 18% of this mean scale. If you say like individual, the score, if you say in 100 scaling, before surgery it was 0, and post surgery we usually get 60 to 70 in between. The light touch sensory scores also, that also improves. So like before, if it is in if it was 48 a score somewhere in the patient, so we have seen after the stimulation, after the 2 months, the score somewhere stands between 70 to 18 out of 112. Pinprick sensory also, that also improves patients. The patients we have seen, here we have taken the 4 patients. I am just showing the data of the 4 patients where we have the pinprick sensitivity, the minimum it was 52, and after the 8 weeks of that, the pinprick sensation increased to 76 out of 112. And this is the scaling. This is for the spasticity. As I told you before that, because of the spinal cord injury, because of the spinal networks damaged, patient usually have the spasticity. So we have seen patient with a complete spinal cord injury have a grade 3 spasticity, and incomplete spinal cord injury around 1 to 2 in between it. And after the electrical stimulation of the epidural region, the spasticity comes down from grade 3 to grade 2, and then it comes to the grade 1. If you see here the graph, what I'm trying to show it here, so this is the patient who has the before, so this is the patient who has a before the stimulation, this much of spasticity, and when we started giving the treatment of the electrical stimulations, so the spasticity started coming down here. So we got from the grade 3 the patient's spasticity to the grade 1, and same like other patients also, the spasticity started coming down. But the spasticity, it usually takes 2 to 3 weeks time to reduce it. And for spasticity we have different formula to keep the electrodes active, and also we usually keep 0.5 volt to 1 volt. We don't keep the higher amplitude. Instead of higher amplitude, we keep higher pulse width and moderate frequencies. Those usually helps to generate the plasticity, the neuroplasticity, and once the neuroplasticity generates, that usually helps to reduce the spasticity of the lower limbs. This is the some programming combinations, like how we try with the patient. So we try patient with a supine position, then sitting position, then standing position, and this is a stepping pattern. So if you see that, in our study, so what I'm trying to show it here, the patient who has supine position, so they have a different context in the activation. When they come to the sitting, it's a different context. In a standing, and the stepping, there are 2 different contexts. And also amplitude, pulse width, and frequency also varies, because when patient comes with a stepping pattern, we usually try to the frequency lower, pulse width as it is, like we usually keep pulse width from 120 to 240 in between it, and amplitude varies. Some patient good with 2 volt, some patient needs 8 volts, depends on the patient's the responses. Now if you see, this is a scale, this is our walking index scale, which we call as a whiskey scale. So we take every alternative months, we usually do the scaling for our patients, those who got, those who are undergoing the treatment for epidural stimulation. So you see, this is the ability of patient before epidural stimulation to stand, or maybe to able to initiate the stepping. After the stimulation, see where the patients are reaching to their ability of stand or to initiate of the stepping. Now the good question is here, that how much patient can able to work with this epidural stimulation. Epidural stimulation with the patient, after switching on, the patient can able to walk around 200 to 300 meter on a first round itself. When we go for the second round, patient can able to walk 500 to 600 meter. So far in our 200 patients, we have seen around 70% patient post surgery after 6 months, they are able to walk more than 500 meter at one time with the stimulation on. And this epidural stimulation, how it improves the bowel movements. So we have done study for the patient who, those who have a patient for the epidural stimulation. So we have just showing, I'm showing here only our 4 patients databases. So we usually do the bowel assessment also, for these patients alternative month. So how the sensory things are improving, because we need to see that. And we have seen the patient who has a zero awareness of the bowel movements. After 2 months, their scenario completely changed up to 50 to 60%. They started feeling the bowel movements. And we have seen also, the patient who cannot have a good bowel movements or the bowel control, lateral bowel movement. So we usually also support the patient with a sacral nerve stimulation. The sacral nerve stimulation we usually do the patient who has an injury more than 20 years of the spinal cord, because we have seen the patients with a 3 months to 6 months and 6 months and 9 months onwards to the 10 years. In between, if we do electrical stimulations, patients bladder and bowel improves. But if the patients, but this improvement, it is not that improvement that it can come back to the normal level. No. So if they want the more improvement into the bladder and bowel, we always suggest go for the spinal cord, go for the sacral nerve stimulation. So I'm going to conclude the things today now, because it is not a rocket science what I'm talking about the epidural stimulation, but it is a very fascinating things what we do when the spinal cord injury. It's a very devastating things into the world. And once the patient has a spinal cord injury, the quality of life, it's absolutely nothing, like it's absolutely zero. But with the help of this epidural stimulation, at least we can improve the patient's quality of life 50 to 60%. I'm not going to say it is going to improve 80 to 100%. No, it can improve 50 to 60% of the quality of life. It improves patient ability to stand. It improves patients, to ability to move around the house or to do his daily activity for the living. And in our experience, what we have noticed that the propriospinal network and the descending reticulospinal commands are very important in this epidural stimulation, because if patient have a good combinations of this propriocepting, the afferent and the motor neurons responses merging with the current or with the stimulation, the patient's improvements much higher. But still, epidural stimulation, it still needs more and more clinical, multi-center trials. It needs more patient databases around the world. And Dr. Susan Harkema, she does the work on epidural stimulation. It's been last 10 years she is doing it. Professor Putin also, she is also doing it many years. And in my center, we are doing it. It's been last 5 years. We are working on these epidural stimulations for spinal cord injury, and we have seen that what we have understand from our experience is like every patient is different. Every patient. So when we say that every patient is different, it means the way of programming, the way of surgery, the way of putting the electrodes, everything is different. Like it's like no patient is similar to the other patients. So it's a very time-taking process. Yes, it's a time-taking process. This therapy, it's a very time-taking therapy. We need to give lots of things into it, but we usually combine the proprioception's improvement, into this spinal cord stimulation, epidural stimulation much more, because when the proprioception started improving, and the patients, the stimulation also the effects include, improves more. And nowadays, there is a company, it's called Cyberdyne. They launched their devices. They say that can improve patients' ability to walk. in our experience, we have seen that when we combine electrical stimulation with cyberdyne, it doesn't work together, because cyberdyne has its own bioelectrical sensors, and when we stimulate with this epidural stimulation, those two sensors usually go completely opposite. One side muscle is firing, other side muscle is not firing. One side muscle is firing high, the cyberdyne's biosensors are not able to catch that. So what we do cyberdyne for first 2 to 3 weeks without epidural stimulation, and once we generate the stepping pattern, we usually avoid the combine the cyberdyne with epidural stimulation, because it is our experience we have seen while trying to compare or combine the cyberdyne with epidural stimulation, our patients lost the complete stepping movements with the epidural stimulation, because the bioelectrical signals in between somewhere plays around the sensory motor and also the proprioceptional network. What I was trying to tell, that that doesn't go together. So that's our experience so far in 5 years what we are doing it, and on the epidural stimulation for the spinal cord injury patients, and we have published few papers also regarding this, how we do spinal cord stimulation, and so far we have done around 200 cases for our center, and we are looking for more patients to do it. We are looking for to do more clinical trials onto the spinal cord stimulations, and hoping that we will have a great connections between the Russian federations and the India, and we can do some more clinical trials onto this epidural stimulation.
Thank you so much. Fantastic talk. Thank you a lot.
No, so this talk actually needs more time and it needs more thing to show. But I want to show few videos of my patients, how they do before and after stimulation. I just like to show. Just a minute.
I don't think we see video. Yeah,
is it okay? Can you see the video?
No, not yet. I see only the folder with video, but not video itself.
1 minute. Is it viable now?
I think the same. So I see only folder. You know, maybe yeah, if you can check how you share screen, maybe you just share the folder instead of the whole screen. Sometimes it happens.
I'm trying to share this, but
yeah, I hear some sound from video, but I don't see video.
If you see that no sound and this, okay.
Yeah, unfortunately, still the same.
Can you see that something now? No.
No, I can only hear some sound from video, but I see the folder with 2 videos here.
Okay, I think it's some ways to show the videos.
Can you maybe start video and close the folder? And yeah, maybe if you can start the video now.
Just let me see once.
Elvira, do you have any thoughts how to do it?
I'm just also trying to find out, because in this Microsoft Meet, it is sometimes I usually get confused, you know, how to show these videos. Let's see.
No, it's no. Okay, it was close.
Can you hear me now? Yeah.
Yes.
You can.
Yes.
So could you please insert your video in your presentation and try to play it
Try to do that. Okay.
from the presentation?
Okay.
Нормально? Ничего, дома, лечится. Я прошу прощения, отключите, пожалуйста, звук. У кого звук включен сейчас?
Elvira,
Yeah, I tried different way, but it's not working. It's too.
Pritam, another option you can send video on over email, and we can try to run from there.
Sure, I will do that.
And you can maybe see me just in case, so I can try on my end.
Sure, I will do that.
Кстати, я не верю, что мне получится подсоединиться, загрузить, потому что я сейчас с телефона все это загружаю.
Перешлите нам, Александр, мы с себя запустим видео.
Хорошо, да.
И вашу презентацию тоже перешлите нам.
Ну, я сейчас попробую еще раз подключиться, может быть, вот, когда будет перерыв, мне получится все сделать. И пришлю, да. Okay, sounds good. Okay, maybe we can
either I am sending you those videos over email to you, and maybe you can try if you can play those. I'll just send it to you.
Awesome, thank you. So I will wait for your email, and maybe we can discuss. I'm sure people, colleagues, have a lot of questions.
Yeah,
so
till then, let's discuss about the questions. Yeah, please.
Yeah.
Thank you, Dr. Pritam. You have great practice, and I would like to ask you about the process, starting from how patient comes, decision making, and the rehabilitation process and program adjusting. Could you tell about that shortly?
So we take patients, usually those who has a spinal cord injury above the 9 months, because initially patient you know they have spinal shock. So we usually try not to take those patients, those who are recently diagnosed with spinal cord injury. So we take patients, they have diagnosed at least more than 9 months. And then once we select those patients, we do lots of the criteria, like from spasticity level. Then we go back to the patients, the muscle testing, how much muscle wasting the patient has. Then patient the sensory, the conduction, the things we do, how much patient has a sensory involvement. Then we do the study for the analysis for the patient who has the bowel and bladder, these things. Like, it's most important thing to finalize it that when we take patients for epidural stimulation, how much improvement we can get for those patients depends on the patient's criteria of the disease, at the level of injury and all those. So if patient has the level of injury less than T5, like T5 to T11 in between, then the patient's improvement is much faster, and the patients, the response is also much higher. Like within 45 days we can get back patient's ability to stand and to take steps. If patient has a high cervical spinal cord injury, like from C3 level to C6, 7, maybe T1 or T2 or T5. So for that, it takes longer time to get back the patient's the stepping pattern, because we get the stepping pattern easily. But when patient has a high level of spinal cord injury, it takes long time to patient stabilize it, make them able to stand, and then after them to make them able to walk. So that usually take 2 to 3 months time.
Thank you so much. And what about program adjusting?
Yeah, so that is the most robust and most laborious process after the spinal cord stimulation, like after epidural stimulation, because each patient needs different adjustment of programming, and also the same time each patient needs different way of the treating. Like if patient has only the spasticity, then we keep a different program mode. When we see the patient has spasticity, with spasticity, some patients have what I can say, the muscle wasting and all those. So for them it takes lots of time to regain the programming, to readjust the programming accordingly, so patient can get back to the full strength, or at least we can utilize the epidural stimulations, the functionality for those patients.
Thank you so much. And could you tell me, please, how many people involved in the process? Which specialists are working with patient?
So we have around 20 people team, those who are working behind this epidural stimulation, and in that we have 5 expert programming person who knows how to program the devices according to the patient standing, patient resting, patient supine position or stepping pattern. Then we have around 15 experts of the neuro rehab team. Those usually take care the patients, the reprogram at the neuro rehab programming part, like how the patient is going to come from the epidural stimulation, then the rehab, then what rehab we should do. So we do passive, we do active rehabilitations together. And also we have a cyberdyne in our center, so we usually find out how much locomotor training is going to help, and after which stage, when the epidural stimulation is sufficient enough to take care the stepping pattern and when is patient able to walk. So what will be the other rehab things, because we need to more focus on to the patient's lower motor extremities functionality, as well as patient's muscle improvements, as well as the patient strength. So when we see those 3 things, the rehab part, it comes like twice a day we do in our center. First we give 1 hour time for the programming of the device, then 1 hour goes for the rehab, and 1 hour patient usually takes time for step, with the current with the epidural stimulation to walking practice. So like this, each patient 3 hours in the morning and the 3 hours in the evening. So they usually spend time at our rehab center.
Sounds like a dream team. Thank you so much. And my final question, I have a lot of, but the program adjusting process is based on what instrumental facilities or tests? What do you use to say, okay, this program is good, this is not?
No, for those patients, I didn't understand the question. Like you are asking for whom? Like after the epidural stimulation, what we do that, or?
Yes, except of the stepping, what else do you use to say, except for example electromyography? Maybe use additional facilities to control improvement, except tests on EMG.
Okay, so we usually combine the EES system. So we usually combine the nerve conduction study while doing stimulating to the patient. We usually try to understand that how much nerves and the nerve systems we are getting back, and also with that we add our FES system, and also we put our the system, the stimulator. So this stimulator, I think it's now many places they use. It's for the muscle stimulator. So we use that muscle stimulator to get the activity of the muscles responses, and how much stimulation is coming and to the muscles. That test we already do the on-table assessment, like when patient comes to the surgery time, and that time itself we put the wireless EMG graphs, EMG machines. So in that we usually get back the responses, that how much muscles is going to responding. But every alternative months we usually take patients the stepping, then patients sitting, then patients supine conditions, the stimulations activity with this EMG, because this electromyography, it's most important to understand how much muscles we are gaining. So we usually focus on the 3 more main muscles. One is in anterior tibialis, because that helps to patients to the able to stand. We take the gluteus, because gluteus is important for the patient's ability to hip control, and we take another one, for the knee support, we for the knee lock and all those. So we usually go with the soleus muscles. So when we have these 3 different muscles activity in one level, we understand that patient will able to walk by themselves. But we usually take around 2 to 3 months time. Every time with the EMG machines, we put different analog for analyzing the muscles activity with the stimulation. Like sometimes with a low amplitude, sometimes we go with a higher amplitude, sometimes we go with a medium amplitude, just to find out that which amplitude patient is adjusting and which is not. And this is another interesting study came up from this analysis. We have seen that as long, if the patient is taking stimulation 1 month, it requires high stimulation. If patient takes to the more than 6 months stimulation, so automatically the stimulation parameters start coming down. So in 5 years, we have seen around, out of 200, around 15 patients able to walk without any stimulation.
Thank you so much. Very interesting work. Thank you.
Thank you.
Thank you, colleagues. Please have any other questions? So, Pritam, may I ask you, so you mentioned you have data from 200 patients, right, so far. I'm just curious, how long it took you to get this data, because it's quite impressive. So you implanted 200 patients and you've been able to analyze their performance over a few months, right?
Yeah, so what we do, we usually start collecting data post-surgery, post-stimulation 1 month, and we usually go up to 6 months, and then we take 1 year, then 2 years, then 3 years data analysis, the data of the patient. So the patient usually comes back to us, like first 3 months patient stay with us, then patient go back, then come after 3 months, then stay for 2 weeks to 3 weeks, then they go back, then they come after once again 1 year, because every time whenever patient comes back, we usually do programming, the readjustment of the stimulation, readjustment of the frequency and the pulse width. So we have a data so far around 200 patients from day 1 to so far till now.
So basically you do adjustments every few months, right?
Depends on the patient. Some patient comes after 6 months, some patient come after 3 months, but we usually suggest to patient come after every 3 months.
And Meska, so from those 200 patients, how many patients have clinically complete, motor complete, sensory complete injury? If you basically split them in Asia scale. So
in these 200 patients, so all 200 patients we have chosen for the complete spinal cord injury. Like there was a no motor and the sensory part. If you see for the whole epidural stimulation, we have done around 450 patients. In that 250 patients we have taken with the Asia B to Asia D, and this 200 patients, it is only completely Asia A.
Okay. Now it makes sense. Okay, and Meska, so then when you presented those data, I'm not sure it was clear to me when you talk about improvement. Are you talking about improvement with stimulation when they have stimulation, or you're talking about improvement over time when they don't have stimulation, or both?
So that's a very nice question. So we have seen when patients have stimulation initially after surgery, they usually able to work with stimulation. As the chronic stimulation goes on, like as the patient's time is going on, like after 2 years, we have seen 20 patients, they don't need any stimulation. They are able to work without stimulation. They just switch off the battery and they are able to work by themselves with a walker.
And what time usually you enroll them? Like how much time after injury?
So in that 20 patients, we have around 5 patients that injury it's at 3 years old, and we have another 7 patients who has around 7 to 8 years of injury, and other all patients more than 10 years.
Okay. But basically it's at least 1 year after injury, right?
I usually take patients those who have at least 9 months because post injury. Because I usually wait for the spinal shock to go away. Then I usually go for this epidural stimulation, because otherwise if patient has a spinal shock, sometimes it's very difficult to understand is it incomplete or it's a complete.
Right. Yeah, it's very good study. I think right now it's very inconsistent results on long-term effect, because there are a couple papers saying that if you use stimulation in clinically complete motor sensory or motor complete injury, over time you may see some volitional movements even without stimulation, right? I don't think anyone reported so far capacity to walk or even walk in upright system in bodyweight support. It was just separate movements, right? So I think your data is quite important, and since like you have
yeah, so far what Cotin or Susan Harkema they published, they only showed that patient improves the motor part and
with stimulation.
With stimulation. The databases what we have and what we are going to publish, we are showing that patient improves the motor plus sensory together. Because we have seen patients, after 2 years, we have 3 patients from Turkey that they came for epidural stimulation in our center, and after 2 years, they actually got back their complete functionality of the sensory nerves, and their sexual function also that they got back, which was very, very interesting from our other patients. We have many patients, but yes, those 3 patients, they got back their sensory part completely. Their pinprick sensations improved, their bladder and bowel movements improved, and as well as their ability of walking and standing, that also improved. So what we do, we not only focus only for motor function, we try to focus the sensory part as well as. So and Cotin, he has published few papers that where he said that non-invasive spinal cord stimulation he tried for incomplete spinal cord injury patient, and he feels the patients improve. I have tried many things for the non-invasive spinal cord stimulation. I have tried epidural stimulation, I have tried cyberdyne into it, I put cortical stimulation, I tried with spinal cord stimulation, like how you do pain management, everything I have tried. In incomplete spinal cord injury patient, after some time, they usually get back their proprioceptors, and once the proprioception started coming back, the patient's ability to stand and walk, it's improved much better. So in 250 patients, like total we have 450 patients databases, in that 250 patients we have selected from Asia B to Asia D, and when we have seen the patient comes to the Asia C, the patients improves more than 90%. And the databases what we have, that we are saying that our patient from Asia A, after stimulation, they became Asia C.
Yeah, so I think those are all good points. And one of limitations of current studies, it's low N, right? All centers who are publishing data, they usually have N1, 2, 3 maybe subjects, and it works well for motor control, right? Because you have yes or no. For sensory control, it's not enough, and definitely having at least a dozen or a few dozen patients would be much better approach to get some comparison between patients in terms of sensation and other functions, and this definitely need to be done this way. And so, Meski, I remember you had a slide with parameters of stimulation. So overall, it was between 35 and 50 hertz, right?
Correct.
Depends on condition and patient. Yes. So within this range, 35 to 50, would you see some specific benefits from a higher or lower frequency in terms of all those functions, or not?
Yes, we have seen. So initially we need higher frequency to get the stepping pattern. As the stimulation goes on, as as after some time, like after 2-3 months, like why patient needs to come every 3 months, we usually ask for 1 week, because as the stimulation going on, like the chronic stimulation makes the frequency to start coming down. The patient who was better with a 50 hertz initially, after 3 months, he or she require only 40 hertz. She doesn't need the 50 hertz.
And your outcome you measure is motor control, right?
Yes, with the motor control.
Capacity to control, volitional motor control, right?
Yes. Yes.
Yeah. And did you try lower frequency, like 10, 15 hertz?
We have tried with the lower frequency with the 10, but not immediately we have seen patient after 1 year or 1.5 years, they are able to work with a 15 to 20 hertz.
Yeah, because there is overall assumption based on data, of course, that low frequency around 15-20 hertz could be more efficient for standing and balance, right, rather than high frequency up to 30,
because,
40.
One problem also it is there when patient has a spinal cord injury, the knee lock, it's most important.
Yeah.
Because patient's knee lock comes from the sensory part. So when we go to the much lower frequency, like if we go more than 20 hertz, the patient who has a good knee lock with 30 hertz, that usually goes away. So we usually try to maintain that frequency where patient will have a minimum frequency with the knee lock. So we have figured out that 20 to 30 in between, that is a good frequency where patient can use it for longer time without any damages with a good knee lock. So at least patient will be able to work by the worker by themselves.
Right, and again, for the same slide, I think you mentioned intensity was quite low, right, up to 3 volts.
So if you talk about amplitude, we start from 0.1, we go up to 25 millivolt, up to 25 milliampere. So 0.1 ampere to we go to 25 milliampere, but so far we didn't need more than 10 milliampere. Our patients, they very well tolerated with 8 milliampere to 10 milliamperes. The more higher amperes we go, patients started feeling the burning sensation and all those to the lower limbs. And the pulse width, we try to keep 180 hertz to 140 microsecond to 240 microseconds in between.
Yeah, Pritam, I just got your file, your link. I'm trying to forward to our colleagues in Kazan so they can open it. Because I'm not sure I can open it here. I'll try. Yeah. Thanks so much. Because now I think this is another issue. Several recent data demonstrate quite a good kind of robust spastic motor control, right? And but this type of movements generated by quite high intensity of stimulation, and I'm always curious what type of real response you see there. And those teams, they don't really show electrophysiology